Hello, good afternoon. This is a recording for neuroanatomy of the visual pathways and the stroke syndrome associated with it. First of all, a quick recap of the visual pathway. As you can see, the visual pathway starts from the retina. The temporal aspect of the retina receive information from the nasal side, and the nasal aspect of the retina receive information from the temporal side. So out of all the information received, nasal receive around 55% of the total fiber, and temporal side of the retina, which is carrying information from the nasal aspect, receive 45% of the total information, or the amount of light which is reaching the retina. 45% is carried by those coming from the temporal side, and 55% is carried by those coming from the nasal side. So nasal has got more contribution in carrying the message. So this is important to understand when we discuss the pathway, especially the light reflex. Why do we get relative afferent pupillary defect in case of optic tract involvement, and which side would be dilated compared to the other? If we know this information, that would be useful. Now, first of all, the information from the retina goes through the optic nerve onto the optic chiasm. The temporal fibers do not cross, they remain uncrossed, whereas the nasal fiber, they cross and they continue as the optic tract until they reach the lateral geniculate body. The lateral geniculate body is situated on the thalamus, and it is situated at the back end of the thalamus, and it is one of the important center for the relay of this information. Now, why do the information do need to relay in lateral geniculate body? The reason being, lateral geniculate body receive around 40 times more fiber from cortex and brainstem than it received from the optic tract. In other words, there is a heavy connection coming from the cortex and the brainstem, which is modulating the information which is brought by the optic tract. In other words, what this information is doing is to only screen all the information coming through the optic tract and allow those information which are useful. So that's why there is a term we see, our eyes only see things which our mind want to see. So that's the reason, because the cortex and the brainstem fibers which are relaying in the lateral geniculate body modulates. They are all inhibitory fiber. They modulate the information which is passed from the lateral geniculate body to optic radiation and subsequently to the occipital lobe. So from the lateral geniculate body, the information goes as radiation. So as you can see, this is the retrolenticular part of the optic radiation, and then the upper radiation and the temporal radiation or Mayer's loop, which goes along the temporal lobe, and the upper radiation which goes along the parietal lobe to reach the occipital cortex. And it reaches along the upper, so if this is the calcarine fissure, it reaches the upper and the lower bank of the calcarine fissure. And it is worth remembering, all the macular vision fiber goes to the tip of the occipital cortex. So they reach the tip of the occipital cortex, whereas the other fiber is more situated slightly forward to that. So once the information reach to the occipital cortex, which is the area 17, it then goes to area 17, 18 and 19, which are the associated visual cortex. And from there, the information goes to the parietal lobe. So the information from the occipital cortex will go to the parietal lobe and the temporal lobe. The information which is passed on to the parietal lobe, that helps to locate the object in the three-dimensional space. Where is the object? What is their speed? What is their exact location? And all this information are provided by the parietal lobe. So that's why it is also called where pathway. So where the object is in three-dimensional space, we can understand. So this is also called dorsal stream, which helps us to understand where the information is. And then there is ventral stream, which goes to the temporal lobe, which is responsible for identifying the object, what the object is, be it a pen, be it a pencil, be it a glasses, or be it human being's face or an animal face, whatever object that is going through the ventral stream in the temporal lobe, which is helping to recognize it. So if somebody has got damage in the temporal lobe, they get what we call agnosia, inability to identify object, although they can describe it, but they cannot exactly say the name of the object. And if there is problem in the parietal lobe where the dorsal stream is damaged, obviously they will struggle to find the object in the three-dimensional space. They might not be able to reach the object properly, and as well as because the parietal lobe also process the information about the attention, they can have problem with visuospatial attention as well. So this is in short our visual field. Now we will quickly discuss the blood supply of the visual field. So this is an image where we're showing the blood supply of the visual field. As you can see, the green area this is the area, this is the optic nerve here, coming to the optic chiasm, then it's the optic tract going on to the lateral geniculate body, and subsequently it's going through the optic radiation and it's going to the occipital cortex. So the parts which are optic nerve, optic chiasm, optic tract, lateral geniculate body, and the optic radiation, and finally the occipital cortex. Each part is supplied by different sets of arteries. As we know, optic nerve is supplied optic nerve is supplied by the ophthalmic artery, which supplies the optic nerve as well as the retina, and we will come into slightly more detail about this optic nerve and the retina blood supply. Next part is the optic chiasm. It has got multiple blood supply. It is supplied from anterior cerebral artery. As we can see, this is the anterior cerebral artery, and so there is branch coming from the anterior cerebral artery, as you can see, supplying the optic chiasm. It also get branches from the optic anterior communicating artery, which joins between the two anterior cerebral artery, and this artery sends also branch to the optic chiasm. And there is also branch from the superior or the hypophyseal artery, which is again the branch of the internal carotid artery. So the optic chiasm has got multiple blood supply. and that is one of the reason it is very uncommonly affected in stroke, because the blood supply is coming from so many different sources. The next part is the optic. The next part is the optic tract. The optic tract receive blood supply mainly from the anterior choroidal artery. This is the anterior choroidal artery where I am. So this artery mainly supplies the optic tract, but it has also got some minor branches from the posterior communicating artery. And as we can see, again, whole of the optic tract is essentially supplied by the anterior circulation or the carotid system, because posterior communicating artery is a branch of the internal carotid artery. Anterior choroidal artery is also the branch of the internal carotid artery. The next part is the lateral geniculate body, which has got again dual blood supply. It is supplied, the lateral half is supplied by the anterior choroidal artery, as we can see, and the medial half is supplied by the posterior choroidal artery, which is a branch of the posterior choroidal artery is a branch of the posterior cerebral artery. So posterior choroidal artery. So lateral geniculate body, the lateral aspect is supplied by the anterior choroidal artery, which is a direct branch of the internal carotid artery, and the medial part is supplied by posterior choroidal artery, which is a branch of the posterior cerebral artery. So it has got blood supply both from anterior circulation as well as posterior circulation. Next come the optic radiation. Optic radiation has got predominant blood supply from the middle cerebral artery, but part of it is also supplied by the posterior circulation, either mainly by the posterior cerebral artery. And last but not the least, occipital lobe is predominantly supplied by the posterior cerebral artery. However, the tip of the occipital cortex has got dual blood supply. The tip of the occipital cortex has got dual blood supply, and it is supplied by both posterior cerebral artery as well as middle cerebral artery. And that has got importance when we will discuss the different lesion what we can get. Now coming on to the optic nerve. So if we summarize, so the retina and extracranial part of the optic nerve is supplied by the ophthalmic artery. The intracranial optic nerve and optic chiasm, anterior cerebral artery, anterior communicating artery, and superior hypophyseal artery. The optic tract is supplied mainly by the anterior choroidal artery, but part of it is also supplied by the posterior communicating artery. And lateral geniculate body, as I said before, anterior choroidal artery supplies the lateral aspect, which is part of the anterior circulation, which is part of direct branch of the internal carotid artery, and the medial aspect is supplied by the posterior choroidal artery, which is a branch of the posterior cerebral artery. Optic radiation has predominant supply from the middle cerebral artery, but it has got some supply from the posterior cerebral artery. And last but not the least, the primary visual cortex. It is mainly supplied by the posterior cerebral artery. However, tip of the occipital cortex has got dual blood supply, one from the PCA or the posterior cerebral artery, and also from the MCA. So if there is a blockage of the PCA, for example, the macula is spared because there is still blood supply coming from the middle cerebral artery. Okay, so that's one aspect. Now we will quickly discuss about the blood supply of the optic nerve and the retina. So this is our retina. This is the head of the optic nerve. So the optic nerve and the retina is predominantly supplied by the ophthalmic artery. So ophthalmic artery divides into posterior ciliary artery, and central retinal artery. Now there are this central retinal artery supplies the retina, whereas the posterior ciliary artery supplies the undersurface of the retina. So all the undersurface, the part of the eye which is below the retina is supplied by this ciliary artery, posterior ciliary artery. Now there are different types of lesion we get to see. If the central retinal artery is occluded, or if the branch of the central retinal artery is occluded, which is usually embolic, and the causes are usually same as we see in the hemispheric or in the brain stroke. So the features would be, because the central retinal artery is occluded, the retina will be devoid of any blood supply, so it will become pale. But because the undersurface, which is supplied by these ciliary arteries, they are still supplying the undersurface of the retina, the other structures of the eye below the retina. So they will be completely vascularized. So when we see the retina, there is a portion called fovea where the retina depth is the least. That part will be still visible. The undersurface can be seen through this. And because the blood supply is still intact, we get what is called cherry red spot. So if there is occlusion of the central retinal artery, we get cherry red spot because the undersurface of the retina is still vascularized, and that's why we can see it as a bright red or cherry red spot through this is the fovea where we can see it. So if a patient present with a central retinal artery occlusion, we should investigate them for the embolic source, like we do for the a brain stroke. So CT scan, carotid Doppler, CT angio to rule out AF, and all the risk factor what we do for stroke, that will apply here. Whereas if there is a thrombus sitting in the central retina, in the ophthalmic artery, proximal to the point where it divides to central retinal artery and the posterior ciliary artery, then the retina will appear pale, and as well as because the posterior ciliary artery is not supplying as well, there won't be any cherry red spot. The commonest cause of occlusion of the ophthalmic artery proximal to its division is usually arteritis or giant cell arteritis. So that's where we should take the history, whether the patient has got any headache, whether the patient has got jaw claudication, whether the ESR is raised, CRP is raised, whether they have got history suggestive of polymyalgia rheumatica, and if that is the situation, they should have high dose of steroid and have temporal artery biopsy, etc., to diagnose that. Whereas if a clot is sitting in the posterior ciliary artery, but if the central retinal artery has escaped, or if there is a so that condition can be divided, that condition give rise to edema of the optic nerve head, and they present as ischemic optic neuropathy. So ischemic optic neuropathy can be mainly of two types, non-atteritic ischemic optic neuropathy or arteritic ischemic optic neuropathy. By far, non-arteritic is the commonest here, and the common cause is similar as we see in small vessels disease, and sometimes we see if there is hypotension for any reason, if the patient is septic or during general anesthesia, etc., or they have extensive small vessels disease, so they can present as ischemic optic neuropathy, where the small vessels from the posterior ciliary artery are blocked, and that results in edema of the optic nerve head, and they can present like that. So that is the commonest, but arthritis can also present with ischemic optic neuropathy. In that case, again, they will have history suggestive of giant cell arthritis as discussed before. So I hope it is clear. So if a patient has got involvement of the central retinal artery, the symptom will be loss of vision in that eye completely, and obviously the light reflex will be lost. Now quickly going back to the optic nerve pathway, again I'll just mention one thing about the optic about the light reflex. How is the information carried? So from the for example, if we this is the right side and this is the left side, if we go onto the right retina, if we throw light onto the right eye, the light information will go through the optic nerve to optic chiasm, but it doesn't reach the lateral geniculate body. They leave before it synapse in the lateral geniculate body through the superior biquium, and they go to the midbrain. In the midbrain, they go to two important structure. One is the superior colliculus, which is not the point for discussion for the light reflex, but the information which goes in the superior colliculus develop the reflex like tectospinal reflex. So if an object is coming, we just move our head. That's carried out through that reflex. Whereas for the light reflex, information goes to the pretectal nucleus. From there, it goes to the Edinger-Westphal nucleus, and through the third cranial nerve, it goes on to supplies the constrictor pupillary muscles and the ciliary muscles to help with constriction of the pupil, and also in the these ciliary muscles also helps in accommodation as well. So that's how the light reflex carried, and it is what remembering from the pretectal nucleus here there is decussation. So they not only go to the same side at Edinger-Westphal nucleus, they they connect with the opposite sided pretectal nucleus, which also stimulate the lateral geniculate body, or which also stimulate the Edinger-Westphal nucleus on the opposite side. So that's why you get direct light reflex where the people constrict on the side where you constrict where you throw the light. At the same time, the opposite eye also constrict. This is called indirect light reflex. The right eye, if we throw this called direct light reflex, and the opposite side, there will be also constriction of the pupil. So that is called consensual light reflex. So that is or a indirect light reflex. So the light reflex also happen to the opposite eye because of this connection. Now, if there is a lesion either in the ophthalmic artery or the central retinal artery where the the information for the light reflex is not carried at all, then there will be loss of light reflex on that particular side where the retina is damaged. But if we throw the light on the opposite eye, that eye will be constricted, but at the same time so for example, if the right eye has got retinal artery occlusion, so the light reflex, the direct and consensual light reflex will be absent on the right side, and consensual light reflex at the same time will be absent on the left side. But when we do the light reflex on the left side, not only direct reflex will be present, but the consensual light reflex on the right side this time, the pupil will constrict because of the connection in the around the pretectal part. So that's one. Obviously, this commonest cause is the ophthalmic artery, which is mainly due to anterior circulation. As I said, from stroke syndrome point of view, the chiasm is not usually affected because there are number of arteries supplying it. So it is not very common. The next part is obviously optic tract. If the optic tract is affected, the patient will develop homonymous hemianopia. So if the right optic tract is affected, so if this is the right and this is the left, patient will have left homonymous hemianopia. Sorry, left homonymous hemianopia. I will do it clearly. So patient will have left homonymous hemianopia. Because the macular vision is there, so there will be macular involvement. And if we look at the pupillary size, so if we look at the pupillary size, we will get, if this is right and this is left, we will get relative afferent pupillary defect and the left pupil will appear dilated. And why that is the case? The right optic tract has got information from the right temporal part of the retina and left nasal part of the retina. Because the nasal part carry more information, so when there is a blockage or when there is no information going through the optic tract, the light reflex causing constriction of the pupil on the left side, it will cause less constriction compared to the right. So relatively the left will appear more dilated than the right. The next lesion which can happen is in the lateral geniculate body. It produces a rather interesting type of visual field defect. It's called sectoranopia. So one sector of the, so if the left lateral geniculate body is affected, it can produce this type of defect depending on whether it's medial or lateral, or it can, so different sector of the visual field can be affected. So this is right, this is left. Because the right reticulate geniculate body is affected, so that type of sectoranopia can appear. And here the light reflex, here you will still get the relative afferent pupillary defect, because the first order, if the lateral geniculate body is affected, the neuron which is synapsing in the lateral geniculate body will be damaged, hence the light reflex pathway will also be hampered. So there might be relative afferent pupillary defect there as well. Now in optic radiation, it depends on which part is affected. If the right parietal lobe, for example, is affected, you will get left lower quadrantic hemianopia. Whereas if the if on the right side the temporal lobe is affected, you get left upper quadrantic hemianopia. Okay. Finally, if there is involvement of the occipital lobe, you get homonymous hemianopia, but here the macular fiber is spared or it's not affected. So you get left homonymous hemianopia with macular sparing. At the same time, there won't be any problem with the light reflex. There won't be any relative afferent pupillary defect here. So these are the common presentation of the various part of the optic pathway, and these are the arteries. So in the if the optic nerve is affected, It's the ophthalmic artery. Optic chiasm has got multiple blood supply from the anterior cerebral artery, anterior communicating artery, and superior hypophyseal artery. So it's not commonly affected in stroke. Optic tract is predominantly supplied by the anterior choroidal artery. If that is affected, sometimes it can mimic like total anterior circulation stroke, because anterior choroidal artery supplies the internal capsule. So the patient, if the anterior choroidal artery is affected, patient can present with weakness of the limbs. They can present with homonymous hemianopia, with macular involvement and relative afferent pupillary defect, and they can have a dysarthria because they can cause weakness of the um, they can cause so the anterior choroidal artery can present with anterior choroidal artery can present with problem with the weakness, contralateral weakness or sensory impairment. They can have homonymous hemianopia. They can have auditory involvement as well, because it also affects the auditory pathway. And they can present with dysarthria, which can mimic like a total anterior circulation stroke. The other interesting but uncommon symptom what we see in case of the optic pathway involvement is if there is involvement of the PCA at different parts. So for example, if the occipital cortex is affected, including the area 18 or 19, which is the associated visual cortex, sometimes you can get, obviously you can get homonymous hemianopia with macular involvement, with macular sparing, and intact light reflex. That's one. And sometime you can get, along with that, you can get peduncular hallucinosis. So peduncular hallucinosis, where you get hallucination of brightly colored object. You can get anomic aphasia, so unable to name object, along with that, and visual agnosia, unable to recognize as well, because the associated cortex is important for identifying the shape of the object, color of the object, and so that's why they can have problem with this as well. Now there is a interesting syndrome which can happen if there is involvement of the bilateral involvement of the PCA, what we call Anton syndrome. This can happen in bilateral PCA involvement, bilateral PCA involvement, posterior cerebral artery involvement, where the patient has got cortical blindness with intact light reflex. At the same time, patient is unaware that they are blind. So they might appear as confused. I've seen patient with Anton syndrome where they have got cortical blindness. They are blind, essentially blind, but they are unaware that they are blind. So they might appear as confused. The other interesting thing, sometimes if the PCA is one side of the PCA is involved, transiently it might behave like Anton syndrome. Both the cortex might stop functioning transiently for a period of time. After that period, usually which doesn't last long, the other cortex usually regain the function, and they present with classical homonymous myopia with macular sparing and with intact light reflex on one side. There is an interesting syndrome called Ballian syndrome, um, which is where there is involvement of the watershed territory, Ballian syndrome, watershed territory involvement between PCA and MCA, or posterior cerebral artery and middle cerebral artery, and they present with few of these features. So first is they can present with oculomotor apraxia, so which is an inability to orderly do a visuomotor scanning of the surrounding. They can have perinopsia, where there is persistence of the image. They can have simultagnosia. So inability to recognize the whole image. So they might see a tree, but they might not be able to see the whole forest. So that's how they can present. And last but not the least, optic ataxia, where they have got inability to reach a visual target. So that can be the presentation. So if we summarize, so optic pathway is a very unlike the motor pathway or sensory pathway, where one side is affected. The visual pathway can cause one half of the visual field affected. Now, depending on the area, like first of all, let's summarize the blood supply. The retina and the optic nerve is predominantly supplied by the ophthalmic artery. The optic chiasm has got blood supply from anterior cerebral artery, anterior communicating artery, and from superior hypophyseal artery. All are branches from the internal carotid artery or carotid system or anterior circulation system. The optic tract is predominantly supplied by the anterior choroidal artery and also posterior communicating artery. Both are branches from the anterior circulation. The lateral geniculate body has got blood supply from both anterior and posterior circulation. The anterior circulation representative is anterior choroidal artery, which supplies the lateral half of the lateral geniculate body, and the medial half of the lateral geniculate body is supplied by the by the posterior choroidal artery, which is a branch of the posterior cerebral artery. The optic radiation is supplied by both anterior and posterior circulation. Anterior circulation, it is supplied by middle cerebral artery, and the posterior circulation, it has branches from the posterior cerebral artery. And finally, the occipital cortex is supplied by predominantly by the posterior cerebral artery. However, the tip of the occipital cortex, where the macular fiber goes, has got dual blood supply both from the posterior cerebral artery and the middle cerebral artery. So when there is involvement of the optic, so if there is a stroke affecting the central retinal artery, we get a complete loss of vision on that particular eye. Along with that, there will be cherry red spot if the central retinal artery is occluded. If there is involvement of the ophthalmic artery before it divides into the central retinal artery and posterior ciliary artery, then we get there will be ischemic. The retina will appear pale, but there won't be any cherry red spot, and the light reflex will be absent on that part as well. The common cause of are embolic event if it is central retinal artery, but also small vessels disease or arthritis can be the cause if the other part is affected. As we have mentioned, optic chiasm is not usually affected in stroke, and because of his multiple blood supply, the optic tract will cause opposite sided homonymous hemianopia with macular involvement and relative afferent pupillary defect on the opposite pupil. If there is involvement of the lateral geniculate body, there will be homonymous sectoranopia, or one sector of this homonymous field will be affected, and it can be due to either anterior or posterior circulation. If there is radiation, usually there is quadrantopia, either upper quadrant or lower quadrant is affected, depending on whether the parietal or temporal lobe is affected. And finally, in the occipital lobe, we get homonymous hemianopia with macular sparing with intact light reflex. And there are, if the associated area, if the associated occipital cortex is affected, then or associated visual cortex is affected, that is area 18 or 19, sometime we get, along with the homonymous hemianopia, there might be peduncular hallucinosis, anomic aphasia, and visual agnosia. If the bilateral PCA is affected, we get what we call Anton syndrome, where there is cortical blindness with intact light reflex, and patient is sometimes unaware about their blindness. They are not they are blind, but they are not aware about that. And lastly, I would like to mention Valiant syndrome, where it is due to the involvement of bilateral PCA MCA watershed territory damage. The patient can present with oculomotor apraxia, perinopsia, simultagnosia, and optic ataxia. So these are the common, this is in short the visual pathway, its blood supply, and the common stroke syndrome which can be associated with it. I hope it is useful.